The i-Bougie is a 70 cm long 14 French introducer with a rounded and angled distal tip to facilitate orotracheal intubation in patients where visualization of the glottis is inadequate. The material allows shaping of the i-Bougie according to the shape of the laryngoscope blade. The i-Bougie comes with two types of oxygen connectors to allow oxygen flow through the lateral openings at the distal tip. Preload the tracheal tube over the i-Bougie and hold the i-Bougie together with the tip of the tube at the 25 cm marking. Via laryngoscopy, insert the i-Bougie from the side of the mouth with the angled tip first. For a clear orientation, make sure that the centimeter markings face up, which provides better control of the angled tip in the vertical plane. If the glottis is visible, advance the i-Bougie through the vocal cords into the trachea between 2 and 3 centimeters. After successful tracheal placement, maintain position of the i-Bougie and railroad the tube into the trachea. Maintain visualization of the glottis with a laryngoscope to ensure correct placement of the tube into the trachea. Hold the tube in position and then remove the laryngoscope before finally removing the i-Bougie. Check for correct positioning of the tube by common procedures. If visualization of the glottis is inadequate, as for example Cormack and Lehane grade 3, preform the i-Bougie to the desired shape and advance it along the base of the tongue under the epiglottis. Confirmation is then non-visual by feeling the tip of the bougie click as it passes along the tracheal rings. If a holdup is felt at the 30 to 35 cm marking, then the tip of the i-Bougie reached the carina. Attention! In order to prevent airway trauma, never advance the i-Bougie beyond the carina. In this case, withdraw the i-Bougie to the 25 cm marking. When there is no holdup of the i-Bougie at the 30 to 35 cm marking, the i-Bougie was placed likely into the esophagus. In this case, remove the i-Bougie and reinsert it. If the tube does not advance over the i-Bougie, the bevel tip of the tube may have gotten caught in the arytenoids. In this case, pull back the tube about 2 centimeters and use a 90-degree anti-clockwise rotation to advance the tube through the vocal cords.